I'd like to thank Ananda for the kind invitation to speak today at this iTrue meeting regarding the iTind device, the temporary implantable nitinol device. We're entering a world now where there are numerous options in terms of the surgical management of symptomatic BPH. And over the last few years, we've seen a great deal of interest in the so-called minimally invasive surgical treatments. This is kicked off with the prostatic urethral lift procedure using the UroLift implants. Also involves prostatic artery embolization, as well as Rezoom, which I think you've heard about. And entering this market space then is the iTind device. So what is the iTind device? It's a device which is placed in the prostatic urethra across the bladder neck. It's aiming to for 5 to 7 days as an ambulatory procedure. It is made up of 3 struts which create longitudinal ischemic incisions through the bladder neck and prostate, remodeling the prostatic urethra in an effort to relieve obstruction, improve urinary flow, and improve symptoms. The 3 nitinol struts are at 12, 5, and 7 o'clock, and there's an anchoring leaflet at 6 o'clock, which is used to hold the device in position during the 5 to 7 days of placement. There is also a polyester suture anchored to the distal part of the device, which is used for retrieval. This image demonstrates the incisions made by the device at 7, 12, and 5 o'clock, and this widely opens up the bladder neck and the prostatic urethra. It's not a new device, and indeed the early data was submitted to the Interventional Procedures Committee of NICE in the UK back in 2018, with guidance coming back in 2019. In essence, it was placed in the experimental category in that guidance, and really what they were after was further information from randomized trials, a greater idea about who and what patients were suitable for this, both in terms of prostate size and indeed in terms of the presence or otherwise of a middle lobe, the degree of symptom and flow improvements both in the short and long term, evidence of reintervention rates, and particularly more standard measures of impact upon sexual function. So what data do we have now in 2021? Essentially, there are 3 studies have been around for a while, plus a 4th one which is just published, which we'll come on to. These 3 studies involve men of expected age with smaller sized prostates, but with significant symptoms, flow rate suggested obstruction, and good bladder emptying, that is probably good detrusor function. First study was called MTO1, and this was a single-centered study using the first generation of the device in Turin in Italy. And we can see here that the device treatment led to a significant improvement in IPSS, which is reasonably maintained out to 3 years, as well as flow rate, much in line with the level of improvements that we see with the other minimally invasive surgical treatments of UroLift and Rezoom. The second study was a multi-centered pan-European trial called MTO2, and there's this one which I was involved in as a UK site. Indeed, there were 8 sites across Europe and Hong Kong, and 80 patients were enrolled with a mean age of 60, but again, relatively small prostates with a mean volume of 39 mils. There were the usual inclusion-exclusion criteria, as well as functional endpoint results. We can see here that once again we see a significant improvement in both IPSS and flow rate maintained out to 3 years of the study, again in line with both the UroLift and Rezoom outcome data. We see similar improvements in quality of life as well as post-void residual volume. Effect on sexual function was only assessed using yes/no questions, but in that study, all patients reported maintenance of normal antegrade ejaculation and erectile function. The most common complications were, whilst the device was in place, being hematuria and urgency, with a degree of discomfort and dysuria as you might expect. There was a low level of retention and urinary tract infections. At the end of that study, they did do a failure analysis to look at the 81 patients and see who did well and who did badly, and if there were particular reasons why those patients didn't do so well from the treatment. Nearly 60% of the people who did badly or considered failures had significant middle lobes. Indeed, it was only this variable that was found to influence the likelihood of success of the treatment. MT06 was another pan-European multi-centre study, and not only was this looking to once again examine the effect in terms of flow and symptom improvement of the device, but also more specifically get more standard types of data regarding impact upon sexual function. 70 patients were recruited across the sites, and we see in the table there the same kind of level of improvements in flow and symptoms that we've seen previously. What is interesting is that on the left there, we see that on average, patients return to daily life 4 days following the retrieval procedure, which means a return to normal activity some 9 to 11 days following the insertion of the device, i.e. a really rapid return to normal activity compared to any other treatment option around. MT03 then is the latest trial, and this is the randomized trial against sham required by the FDA to gain approval. This was a multi-centered trial in the US with 185 patients recruited and randomized, and it is the publication of data from this study which led to FDA de novo classification for iTind in February of 2020. This has now been published in the Gold Journal. There were patients who were over 50 years of age and were randomized 2-to-1 from iTind to sham. And the results demonstrated similar kinds of improvement in the IPSS with a decrease of 9.25 and an increase of 3.5 mils per second in terms of flow rate. Adverse events were mild and transient. And in fact, there was little difference really between both the arms. And in particular, there was no de novo ejaculatory or erectile dysfunction recorded. So we now have a whole number of trials, single centre, but more multi-centre, examining the outcome of treatment with the iTind device. And we can see here, as we overlay them, that they have the same kind of level of improvements in IPSS and flow rate, which means that the effect of the device in terms of improving symptoms is reproducible across trials and across multiple sites. We saw in the 3-year studies a durable improvement with an under 9% surgical retreatment rate, which certainly is in line with something like UroLift. Here are the publications as relate to those trials. So what can we conclude then? We can conclude that the iTind is a minimally invasive surgical treatment. It is added to the armamentarium available along with UroLift, Resume, and indeed prostatic artery embolization. We have multiple trials, many of them multi-centered, demonstrating reproducibility of outcome and durability at least out to 3 years with a relatively low reoperation rate. And we have good evidence now that these improvements apparently carry no risk in terms of negative impact upon sexual function, be it in terms of ejaculatory function or impact upon erectile function. So in 2021, we then have the evidence to go back to NICE to answer the questions they had regarding the data to lift it from the experimental category to a more accepted treatment option. And indeed, this data has been resubmitted. We look forward to the publication from the NICE Interventional Procedures Committee regarding the latest guidance. I apologise for the very quick sprint through all aspects of iTind, but I think you will agree that it certainly seems to represent a real option for men who want to have a minimally invasive treatment to improve their symptoms, yet preserve their sexual function. A particular, for instance, may want to avoid the placement of implants or face the prospect of a post-operative urinary catheter. I'm afraid I won't be able to attend the meeting in person, so I won't answer any questions regarding the device, but I'm very happy to do so separately. Again, many thanks for the kind invitation, and I hope you enjoy the meeting.
That was a very nice presentation from Neil Barber. Advantage of Neil is he is like master of everything. They say you can't be a master of all the tricks, but Neil is good in UroLift, Resume, Aquablation, iTind, and he is the main person for the BPH.